the Maine Rural Healthcare Education Grant Rounds. This is all made possible through the Merge Collaborative Grant, as well as the Building Maine Grant, both funded in this year by the Department of Health and Human Services. And so today we're so happy to welcome Dr. Bethany Picker. I'll just share a little bit about Dr. Picker's background. She has been faculty in graduate medical education since 2002 and has been at Central Maine Medical Center since 2006, where she became the program director in 2018. She has led the program to participate in national innovation studies of family medicine education, including length of training study and the Clinic First Collaborative. Recently, she's been focusing on collaborating with her local partners to increase the program's work in the community. So I'm very happy to welcome here to talk about the issues around supporting healthcare learners with disabilities. And with that, Dr. Picker, I'll hand it to you.
Let's try this again. Now what can you see?
So what we see is actually your whole screen, but a minimized version of the presentation. So maybe if you want to make the presentation full screen.
Okay.
And now for some reason, I do see where your notes are. So if you can perhaps, do you have another screen that shows the whole thing?
I do. Yeah, hang on a second.
Yeah, just flip it around. Sorry, folks, just a few technical difficulties here. And for what it's worth, we nailed this before the meeting started. We had it looking great. I don't know what switched. Perfect. Now we're looking good.
Okay, great. Well, thank you for your patience, everybody. So I'm here today to talk about supporting healthcare learners with disabilities. I want to say at the outset that I don't feel expert in this. However, I have had some recent experience that's caused me to do some more reading and some more learning and talking amongst my peers. So I would really want to share what I know, and then together, hopefully we can all learn more. My objectives for today include defining disability and how that might be specific into the healthcare and the health education setting. Thinking about disability with a DEI framework and recognizing the risks of un- or mismanaged disability and some awareness of the pitfalls and ways to mitigate risks to both the learner and the institution. Before I get too far, though, I do need to share the required slides, including where the support comes from for doing this work. And I think, and that I have no conflict of interest. In terms of how to get CME, I believe Dave is going to put this in the chat as well. And then a link to an app for the CME as well. So definition of disability is really the same. It's a physical or mental impairment that substantially limits one or more major life activities. And there's some examples there. Major bodily function includes chronic diseases. And the diseases don't need to be active or in a flare in order to be a disability. So in other words, it could be a chronic issue, which the learner is managing quite well with an intervention such as medications or treatment. And it is not in a flare or currently out of control, but that still qualifies as a disability. The prevalence in the general population is about 28%. These are the kinds of disabilities that make up that percentage. If you add them all up, it's obviously over 28%, and that's because often people don't have just one thing going on. There might be multiple things, and so but that's how that math works out. In the undergraduate medical education, the prevalence of disabilities has been increasing, or at least the prevalence of medical students self-disclosing a disability. It's gone from 2.8% in 2015 up to 5.9% in 2021. And so the percentage increase then from in those 6 years is 110% increase. So there are more, it is probably both, that there are more students entering medical school with disabilities, as well as more students being willing to disclose a disability and seek accommodations. So as we're kind of working within this world, we're going to see more and more learners with disabilities as we continue to do this work. The kinds of disabilities that they are disclosing include the list here. The psychiatric disabilities that are include adjustment disorder, anxiety disorders, including OCD, PTSD, bipolar disorder, depression, eating disorders, cognitive disorders, and schizophrenia. And the other functional impairment was not completely delineated in the article that I was reading, but the things that were mentioned included missing limbs, a traumatic brain injury, and stuttering. So many different kinds of disabilities. And one of the things that I think there's been a lot of push to is to think about disability with a DEI framework and moving either explicitly from DEI to DEIA, including accessibility, or including it in the DEI framework, but being a little bit more intentional about ensuring that its inclusion is obvious as a way to set up a culture of acceptance, of accessibility, and to remove the stigma and the barriers for those with disabilities from seeking accommodations. One of the articles I was reading included a physician who late in life received a diagnosis of some neurodiversity, and his thinking about the intersectionality of how we work with learners who have difference and what we can do to improve their education. So he used an analogy of the child's toy with the shape sorter and trying to have people kind of massage their edges so their clinical thinking and their reasoning can kind of fit in the shape sorter that we're all used to, but also balancing that there needs to be some maintaining of otherness, and we value that in people's thinking. And so trying to balance the shaping of a learner's thought process and how they're kind of going about their clinical reasoning with maintaining otherness, including neurodiversity in that otherness as we think about the DEI framework. So there was a undergraduate medical education questionnaire that was just open-ended with a question saying, basically, what would you share anything you want to regarding your experience with disability in medical school. And then they took all those answers and then they bucketed them into big buckets that you can see above. So the big system issues like working with the NBME for their shelf exams, many students expressed frustration in that they had good support locally at their schools and they felt they had good accommodations as they needed within the test that the school controlled. But when it came to working with the national organization, it was much more difficult. There was a lot of frustration with that. Within the school itself, the pedagogy is really referencing into how things were taught. And sometimes there was a rigidity that was difficult for students to manage in the how they were given information based upon their disability. The temporality references how much and when the information was presented. And that sometimes that made, depending on their disability, the volume of information and the timing of when it was presented with some rigidity, and that also made it difficult for them to have full access to what they needed for their own success. And the environment includes both physical environment and electronic environment. So thinking about how things are presented with somebody with hearing loss and is there captions available, with somebody who has low vision and was it still accessible to them. And the culture, the hidden curriculum is always significant and is very significant when we're talking about disability and accommodating students with disability. And so the effects of disclosure, whether they're real or perceived, and how that affects a learner's willingness to disclose a disability and to seek those accommodations. In terms of that, they then did further question, basically saying, if you felt that you needed an accommodation? Did you request it? Um, and this is kind of the result. So basically, about 1 in 5 students who have a disability who felt that they would have benefited from an accommodation still did not seek it because of some real or perceived barrier to that. This chart does not include students who have disability who felt that they did not need an accommodation. So SWD is students with disability. Later on, I have RWD, which is residents with disabilities. And that's how it's often written kind of in the literature that you'll read. So the students with disability, they have more, during their undergraduate medical education, had more leaves of absence than their non-disabled cohorts. And they often had a delayed graduation. This study really looked at, they took those with students with disability and they chunked them in 2 different groups. One group was a cognitive learning disability and the other group was a physical and sensory disability. The leaves of absence were true for all students with disabilities, and that difference held for both groups. But for the delayed graduation, it was more significant for students with cognitive and learning disabilities. So for the USMLE scores, it was lower for students with disabilities, but that was really driven by the cognitive learning disability group. When they separated out the physical disability scores were a little bit lower than the non-disabled cohort, but it was not statistically significant. And then how do they do in the match? So this is matching to their to a program on their first attempt. It was a little bit lower for all students with disability, but it was more significant again for the cognitive disability group compared to the non-disabled group. And this held true even when they controlled for those step 1 scores, which were also lower. But where are those students going? More students with disability are going to primary care than their non-disabled cohort. And there was no difference between the cognitive learning group and the control group, but there was difference between the physical and sensory group. So most people are getting matched. Most people are they're doing they're getting the supports if they get the supports they need, they're doing fine. It may take the students with disability a little bit longer, and those with a physical or sensory disability are more likely to come to primary care. As we move into a resident experience, residents are uniquely situated in that they're straddling the role of a learner, but they're not still a student, and the employee, but they're still a learner. And so working within that that straddling of roles becomes difficult when you're thinking about disabilities, accommodations, HR, those kinds of things. In terms of intern accommodation requests, so there was a large intern study, and they said, well, how many of you who have disabilities requested accommodations and what was the outcome? So of those that requested accommodations, most were provided. There were a few that were under review. Again, this adds up to over 100% because some residents may request multiple accommodations, some of which are provided and some are under review. But there was none that were denied. And if they didn't request accommodations, but they felt like they needed them, then the question was, well, why didn't you? And so, a lot of it is from the fear of the stigma or bias and how it would be perceived by their faculty or their program. Some of them wanted to, but they just couldn't figure out how. So the institution was lacking a clear process that they understood. Or they felt they needed it, but they didn't think that they had the documentation to back up that request support, so they just didn't bother. And the other was an open-ended response, and the noted answers were things very similar, like not knowing what the accommodations would look like, or they just wanted to kind of figure it themselves and they just put their head down and kept working, or they just didn't want to disclose for another reason. Well, then the question is, what happens to residents who have a known disability, but then didn't request accommodations? And so what is the consequence of that care? So this is looking at interns as they start and then 1 year later, and basically giving them the PHQ-9. And what's the increase of symptom score in that year? So not surprisingly, I guess everybody gets a little bit more depressed during their intern year. And they had, on average, those residents without disability had an increase of symptom score of 2 in that 12 months after they started residency. Residents who have a disability and had their program and access needs met had the exact same score increase. But residents with a disability without having their needs met, then they had a significant increase in their symptom score from 2 to 4.5. Similarly, if you ask them, well, what about major medical errors? So this is a self-report of major medical error in the last 3 months. Again, this is at that same time, 12 months after the start of internship year. And residents without disabilities and residents with disabilities who had met access needs, both had about the same percentage of around 11 to 12. And those without access needs had a significantly increase of self-reported medical error of 42%. So how do we help residents and learners who have disability? The one thing to remember is that they have to drive the bus, right? So we can recognize the potential disability. We can even see its effects playing out, but it's really up to the learner to identify, seek the help, seek the accommodations. We can coach and we can assist, but we cannot insist or even make assumptions. So in that context, then, who is responsible? And it's really a shared responsibility. So if it's a medical student, it's, the learner has to self-identify and seek those accommodations. But the school and the proximate teacher really need to be aware of the accommodations needed and ensure that they're in place appropriately for the student. In the graduate medical education world, it's a similar kind of three-pronged approach where the resident, the program, and the sponsoring institution all need to work together for the resident to get those needs met. Where they're also an employee, often the sponsoring institution would include HR in that as well. When you look at the literature about best practices and what are the best practices, there's some really cool things out there that my guess is most of us have no or limited access to, like a disability resource professional or an educational accommodations expert. So there, a lot of this work is written, and you see the same like 3 or 4 names over and over again. And they're very smart people doing really cool work in really big institutions that have, I think, a lot more nuanced support than sometimes exists in our worlds. So then the question is, well, how do we take the best practices and then apply them to our small institutions here? So often I don't think we have the disability resource professional. We don't have a large team of experts. Our HR is often more familiar with dealing with employees than learners, and having that nuanced conversation often leaves us in a position of being both a supervisor, like an employee supervisor, as well as the advocate and explainer for the uniqueness of the resident role. The faculty is often a mentor as well and an advocate as well as the evaluator. And often even the program director is also the DIO, and that can blur the lines of what should be, like, what information should be known best practices is that there is somebody at the DIO level who might be aware and kind of sit with the sponsoring institution and the learner to kind of ensure the accommodations are met. But the program director and the faculty often are unaware of exactly what the disability is that's requiring the accommodations as they're required to do the accommodations. But where we are often wearing multiple hats, sometimes that ideal state is not possible. And so more is known, and we need to kind of be aware of what role we're in at the moment, and trying to be as transparent as possible with all parties involved. Because there are some pitfalls. One of the things that I've personally seen and is known is that sometimes a student is coming through and they have a known disability, or the disability is such that it's not yet diagnosed, and they've been able to manage it with the work that that's been required of them up to that point. But when they get into the clinical world, the demands are different enough and increase enough with added stresses of sleep deprivation probably being the biggest one, and then a disability that had been previously managed is now affecting outcomes, or a disability that had been masked, even the learner is unaware of it, becomes unmasked because of these added stressors. And so then you often get into the world where there is a intersection of remediation and disability. And so because a previously managed disability is now affecting the work, or becomes aware, the resident was unaware of it, but there is now presence there, they may end up on a remediation plan. And so then you have to balance those two things, because there may be a late request for accommodations. So one of the things that we need to do is ensure that residents know the process, and that we have an accessible and reasonable process for knowing how to get some help, some evaluation, some documentation if needed, and then the process of requesting that accommodation plan. In terms of potential outcomes, is patient safety and professionalism are the two that come up a lot. And when we think about a healthcare professional with patient safety concerns, there really need to be objective concerns, and not just a hypothetical, well, what if this happens or what if that happens? And I think a lot of this comes up, especially with sensory disability, so low vision, low hearing. And so we need to work with learners to kind of really understand what their experience has been, what accommodations they need, and then think about, is there a modification that can mitigate that risk to both the learner and the patient, and really delineate what the patient's concern, patient safety concern is. In terms of professionalism, this is required of all medical learners. And there needs to be clear, if there's a professionalism concern, then we need to have clear language to ensure that it's not a proxy for disability discrimination. So for example, a mental health disability may make it difficult for a resident to attend a rotation consistently. And so there may be an accommodation in place regarding attendance or pace, but there still is a professionalism expectation for the resident to communicate their needs with the program, with the site, so that they can't just not show up. There's still a professionalism expectation, even within the accommodation of a slower pace or intermittent attendance. So what can we do to maximize learners' experiences? So one of the things I think is really thinking about our DEI statements, our DEIA statements. They really, I think, can do a lot to set a culture and to have a hidden curriculum that is accepting, and increase the likelihood of accommodation requests. Because as we've seen, it really affects their work, their own mental health, and patient safety. Having faculty with disabilities is a great way to be welcoming of learners with disabilities. And it's been shown that programs that have more faculty with disabilities have a higher percentage of residents applying with disabilities as well. And then having a clear policy. So anticipating and communicating accommodations. And if you can do that by even ones that you know that would not be reasonable at your site, that they would be untenable. So for example, we cannot accommodate a resident who cannot do nights, as one example. And so if you put that kind of in your policy up front, it's clear, it's transparent, and it saves problems down the line. Your policy should also include steps to request accommodations. And the other thing is kind of sharing that policy early, make sure it's easily accessible to everybody, making sure that your program staff and faculty know about it as well. Faculty knowing the process and the policy is extremely helpful. One of the things that can happen is faculty can have good intentions that go awry. So one of the things is making a change in the moment that seems like it's really necessary and important. But if it's not a change that can be sustained long term, you can be set up for an issue where then you can't then say it's unreasonable because it was made once. But then it may also be unable to be sustained long term. So thinking through the larger picture before small changes are made in the absence of accommodation requests. And then in terms of other faculty development is really doing this, right? And kind of engaging with peers at other institutions, getting some outside perspective of what's worked at different residencies or educational sites. And then that increases the experience for all involved. So that's what I had to share. These are my resources that I'm happy to share. I will say that those that are interested, a great resource is just going to the website Docs with Disabilities. They have a whole bunch of resources readily available. There is a podcast that they have, as well as basically a book that you can download for free.
Outstanding. Thank you, Dr. Picker, for that presentation. I encourage everyone to turn your cameras back on. We have at least 15 minutes here for a question, answer, conversation, reactions. I'll moderate when necessary, but Callie, go for it.
Bethany, thank you so much for that really great outline. I confess I struggle so much with this, and I think we do not have a DEIA policy that really lets anybody know that we are open to residents with disabilities. And I think in part because we're not. And I think it's a terrible thing to say. I think it's difficult with residency, right? And so we too have had and we've got over 300, close to 350 residents and fellows. The number of accommodations that have come across my desk increase every single year. And some of them are really significant. And so they'll match to our programs. And then they'll say, oh, by the way, I can't do nights, or I can't work more than longer than 8 hours, or I need to be, this is one that we're dealing with right now. I have an anxiety disorder. And so if I get negative feedback, I need to be able to remove myself from the clinical situation to go and meditate for 15 minutes while other people are taking care of patients. And so it's very, very, very challenging. And so what I feel, and I'm going to put Ross Hilliard on the spotlight here and ask him to share a question he had with me the other day. I feel that the impact on other residents who are working ridiculous hours, I don't know about your institutions, but we don't have spare residents. And we also do not pay for additional work. So if somebody goes out on maternity leave, we don't pay other residents to do extra care. I'm rambling. And some of these accommodations, and I think the last thing I'm going to say is that my HR and legal department are laser focused on avoiding liability. They are not focused at all on the repercussions of accommodations. So with this one resident who said, I can't do nights, is that a reasonable request or not? Essentially, the legal department said, well, you've got faculty, have them do resident call. I was like, or the entire faculty will resign. So it's just this it's just focused on avoiding liability, which makes it even more difficult. And then what do you do with Ross Hilliard's situation? Ross, I'm sorry, I hope you don't mind, but
That's fine.
I've already put you on the spot because it's a great question.
So in the throes, as I'm sure many are, and if you're not and already done with invitations for interviews, I'm jealous. But in the throes of reviewing applications, I've seen, and my APDs have seen a growth this year of people answering that limiting factors question. Are you able to, do the work of the resident with or without accommodations? Of people actually answering that no, which part of me wonders if they read it and understood what they were saying. But that no answer to with or without one, the heiress question is vague. Like, yeah, really should be with accommodation, in which case we'd go from there. But with or without accommodation is kind of vague. But is an interesting challenge. And what I sent to Callie yesterday for her direction, the beauty of sending something to your DIO to dump it in their lap, of like, hey, I probably would interview or invite this applicant to interview if it wasn't for this. Just not being aware of what that is. Is it something we could accommodate or is it not?
Yeah, I get your sentiment completely, Callie, because I have had similar kind of responses and experiences. In terms of that question that on Eris, I've seen it as well. I'm thinking that many who are answering no don't understand it. I will say that we had one that answered no and then sent this like panicked email to me saying like, I did it wrong. I guess I can do it. I can do it. But I really think that if because I don't think we can ask more about it, right? So if they're really saying no, that they can't do the work, then I don't know. I don't think we should. It's alarming.
The problem is that the heiress question says with or without accommodations. And so what I'm worried about is that someone's like, yeah, with minor accommodations, I can do this job.
Yeah.
And we're not, we're just saying no, because it's unclear. Because I also think there's a bait and switch, because the question is, can you do this with reasonable accommodations? Well, who defines what reasonable? So this resident who couldn't take night call, their reasonable accommodation was they just didn't do it and everybody else does more.
Right.
Which was
so
not
one of the
reasonable.
things I went to a conference on this at the residency leadership summit for family medicine. And the point that they made that we've taken to heart is that you decide what's reasonable for your own setting. And the more that you can do that kind of a priori, the more you can limit those problems. And so one of the things that we put into our policy is that they have to be able to do nights. They have to be able to work 24 hours. And the accommodations can't, I can't remember exactly, but basically significantly alter the experience of other resident learners. Because of exactly, we, like everybody else, we're not swimming with extra residents who could just do other work. And I agree with you, faculty would revolt.
I think what we said in our policy was that reasonable accommodations could not require any alterations to other resident schedules.
Yeah, that's what it was. Yep.
I see Jim's got a hand up.
Yeah, so just so you don't all think that you're alone, we have the exact same issues. Doesn't matter whether you're big or small. You know, we had a recent case exactly like you're describing, where, you know, after it was disclosed that there was a medical issue, it was, well, here's what you can do for me so that I can be successful, except that they wouldn't have met the qualifications for graduation, so that's not making you successful. And we went down the same road, you know, and of course, you know, faculty being faculty, that we are educators and clinicians and helpers, you know, try to help the individual. And then HR is like, well, why didn't you call us sooner? And I'm like, well, if we called you every single time we had a resident have a hiccup, you would never be able to deal with the other 4,000 employees that you cover, and they just don't get that. And Frank and I went through this just recently with a medical student as well, who's not even an employee, but HR is so leery right now about lawsuits over discrimination that you know, they've really expanded what they think is reasonable. And so in our case, for a resident, we simply said, here's what all of our residents are required to do. If you are not able to do the things that they are required to do without something extremely reasonable, then they cannot be a functioning resident. We would not expect that if a housekeeper said, I can't actually do any housekeeping duties, that we would continue to employ them. And trying to get people to understand that that's the same thing with physicians. You know, that if they can't be a physician, we shouldn't be employing them as a physician, is a difficult task. And really, it becomes such burdensome, I feel, on the faculty, because we put in such onerous, you know, hurdles that have to be navigated in order for us to dismiss somebody who can't function at the level they need to be. Whereas, you know, most of us would have said should have been the other way around. And that's from caring people. I can't even imagine what uncaring people think. But you know, we're all kind of dealing with this culture, because I think, you know, certainly in my generation, you know, you didn't even bring up that you were sick. You know, I famously talk about that when you know, in my residency, you were kind of partnered up with somebody through your blocks, like you were always with somebody. And so my partner, once we were on rounds in medicine, and she leaned over and she goes, do you think I should tell anybody my water just broke? You know, so that is the extreme that we shouldn't be looking at. But you know, I get anxious sometimes when I have to talk to people. That's a huge red flag when you're a doctor. And so I
Yeah.
think, you know,
But
One
Jim,
it's
what
tough
you're
for us
saying,
all.
and what you're saying though, is that you're putting a policy, and we just this year put up a job description, like just a formal job description from HR, which leaves a wide variety of interpretation. But by putting that up there, or by putting a policy saying we need to do this, this, and this, we're actually saying we're actually not welcoming to people with disabilities, really. So I think that's one thing. And then what was really interesting with this one resident who couldn't do call, or decided not to do night shifts, he researched and came back to our legal department and said there are family medicine residency programs in the United States where their residents do not have to do night float to graduate. There's nothing that says in the ACGME or the American Board of Family Medicine that you have to do nights. And so it's reasonable that this family medicine residency program should also follow some national standards. And that was super, super tricky. And so we ended
Yeah.
up having to accommodate him. And I won't tell you how we did it, but it was brutal.
Yeah, so I will say that what is possible at one place doesn't mean that it's reasonable at another place. But what's tricky is if you haven't already defined that for yourselves, of then having that kind of retroactive discussion, as opposed to kind of what you're doing now. What we're trying to do now is basically saying that these are the things these are the kinds of things that we can't reasonably accommodate because of the size and structure that we have for this program, and doing that up front. The other thing in the literature that they talk a lot about, and they use the mantra of nothing about me without me, is that interactive process with accommodations, and that it really needs to be a conversation with the person seeking accommodations, with their supported documents about, from a medical professional about what's needed with somebody from the sponsoring institution and somebody at the program or the DIO to think through how to kind of meet those needs in a way that is possible for within the system that it's in. And so that interactive process becomes really important.
Jim, I see your hand up, but I briefly, for the sake of the recording, want to point out a great question that Dr. Hoffman put in the chat, and I see people have replied. Just for those that can't see the chat, the question was, are you sharing these policies on your website prior to the interview or match process? And a response was given from Annie Durthik that yes, but that is the plan. They're in the process of having it finalized and wanting to have full transparency. And Jim, you replied that at Northern Light, you folks are also trying to be fully transparent. If there's anything folks want to add, please be my guest. I just want to make sure people watching the recording could see the responses there.
We just posted not a policy, but the actual job description, the one from HR, that in it says that this person will be able to do 24 hours, including days, evenings, nights, and weekends. So we didn't put a policy, but the actual job description.
Yeah, that and I think that's great, and I'm glad that we're sharing this. This is why this is such a great topic, and I wish more individuals were on to kind of just hear through it, including like members of HR and stuff. Would be beneficial for them to kind of hear the concerns that we have. I'm now I can't remember what I was going to say. Bethany, you made a point, and I was going to say, I'm so glad you brought that up. But that's
sorry.
Was it the interactive process? Is that what you're talking? That's what I was talking about.
Yeah, that's exactly what it was. Thank you. Yep. Thank you very much. Yeah. So what we have found is that, while learners have been very forthcoming that they need accommodations, when you ask them for the documentation to back that up, typically from a medical provider, that is, they are very reticent to actually do that. And whether that's because of embarrassment, fear for their job, or they frankly don't have it, that's been a challenge that we have found over and over again when we're told, well, this is why I need to do this, which is interesting. And and then I've looked at some of our residents who have had freak accidents and wind up with the little scooter, not being able to use their one leg, and yet they're those people have been a lot more like, hey, listen, I can continue to do my job. Please don't keep me from doing this. And we're like, well, yeah, but it's kind of hard to catch a baby when you got the scooter in the way and stuff. And so, it's been a little bit of a challenge, especially when we're talking about accommodations for emotional reasons.
One point I'll say is that, sorry, I don't want to cut Annie off, but that who gets the information, who gets the medical provider should probably not be the program. That probably should be HR. Right. So in terms of the documentation request needs to go to kind of the sponsoring institution or the the system level, and then once that's once the types of accommodations are asked for, that's kind of where the interactive process comes in. So just to try to make sure that we're all aware, so we're not putting a resident in a situation where we're asking for information that we shouldn't be asking for, because then we can kind of get ourselves into trouble too.
Yeah, excellent point. Yeah, when I say we, I meant we as an institution, not we as either a residency or the DIO. Before I throw HR completely under the bus, I will say that it has been fascinating with us, these last two cases that I described, when HR actually got involved with the individual, they were far harsher, and their requirements were far harsher than what ours were when we were being told that we were, not being careful about being gentle and stuff. And I actually pointed that out to them. I said, okay, so I said that this is the accommodation we could make, and you said it's only this over here. Like, you actually made the situation harder for the individual that you were saying we weren't actually, protecting their class or whatever. So.
Ross, I mean, this might have to be our last one.
I know we're at time, so I can hold it. But since we have people who have been experiencing, working through this, the interesting thing I've seen is residents struggling with the fact that the bar for accommodations and testing gets higher as they move through USMLE. And then for me, ABIM's bar is incredibly high. And so folks who've had accommodations all the way through for lots of other things start getting denied, with the same information and the same documentation. And I wonder if anybody has had a magical solution to help other than, buckling down and sending them to, we're lucky enough to have an educational specialist, at least part-time, who we can refer people to.
I have no magic wand for that.
I'm lucky I have Frank Bailey, who's my medical education specialist, and helps me with a lot of those kind of issues.
I have to say, I feel badly. I was at a DIO conference and there was a room of like 300 or 400 DIOs, and there was active hostility from the DIO group to this wonderful person who was saying you should be welcoming because this reflects our patients. This is all about diversity. And she was really sort of critical of the group who are like, she gave a great example, I know we're at a time, but of a deaf candidate who somehow got through interviews because she reads lips really well and has the ability to have on her side language, and didn't disclose that she was completely deaf until she matched. And the institution ended up spending $240,000 per year for a live in-person interpreter. And the DIO's response to that was, that's beautiful. Like, this person who's deaf is going to serve a very important group of hearing impaired individuals for the rest of her career. That was fine. It was when it came to anxiety or neurodivergence or night call. So I don't know. I do struggle with it. And Bethany, I so appreciate you and sort of the review of the literature is again helpful. I appreciate it.
And I'll echo that, the appreciation, Dr. Picker, for this wonderful presentation. Before we all exit, I'll just promote that we'll be doing this again next month on November 8th. We are going to be joined by Dr. Mark Kimball. He's the course director for the competency-based apprenticeship for the primary care at Tufts University. So he's going to be talking to us about models for medical education in a clinical setting, talking about topics such as adult learning theory, 1-minute preceptor, some concepts we've seen before, but a nice review, especially as we bring new folks into the fold for these grand rounds. So we hope you'll join us on November 8th. Thank you, everybody. Thank you again, Dr. Picker, and we'll hope to see everybody then.
Thank you.